देखो आगे लिंक खुल गया, देखो उसी लिंक पे दोबारा क्लिक कर लीजिए। हाँ ठीक है,
नहीं वो लिंक एक बार फिर से भेजना है सर, आपको रिटर्न भेजा है स्टडी 3 से दोबारा भेजा है। अलग है ये लिंक।
विक्रम जी क्यों ढूंढ रहे कुछ? विक्रम जी बोल रहे हैं कि वो क्लास कराया जा रहा है, सर तो नहीं याद कर रहे।
सर वो आपको पहले बुला रहा है,
बोल देगा क्लास।
ठीक है, नहीं वही लिंक है। हाँ लिंक तो मैं ये कर देता हूँ, नहीं तो सबको भेजना पड़ेगा ना।
नहीं नहीं आप स्टार्ट कर दीजिए।
नहीं लिंक तो भेजो चलो कोई नहीं, आप फोन कर।
स्टार्ट
शुरू हो गया।
हाँ
शुरू हो गया ना।
हाँ
ये अभी लिंक होगा ना तो Yeah, sending the new link. नहीं सेम लिंक है। या हाँ हाँ व्हाट्सएप खोलो। तो वो उसमें भेज दो हमारे एक हेड एंड नेक एमसीएच को। एक और लिंक भेजना है शायद, तो मेल भी कर देता हूँ। ओके व्हाट्सएप में भेजा है, आईडी में भेजा है। मैं दे रहा है, देखना शुरू करता हूँ। Good afternoon, respected teachers and colleagues. Today I'll be presenting the Journal Club on a topic multi-center trial of 18 FDG PET CT staging of head and neck cancer and negative predictive value and surgical impact in the N0 neck. Results from ACRIN 665. It is a non-randomized trial done by Valje Lowe et al. And published in Journal of Clinical Oncology 2019. Positron emission tomography, called as PET with CT, using 18 FDG is reliable in detecting lymph node metastasis in head and neck squamous cell carcinoma. This was quoted from the article published by View IS et al. However, data on PET CT in clinically N0 neck is single institutional and retrospective. Most prior studies report a high sensitivity and specificity for PET-CT, but there are generally false positive readings. When PET achieves a high negative predictive value for N0 neck, it may avoid unnecessary therapy for the neck, which will reduce the expense, the time lost from the work, and treatment-related morbidities. The objective of this study is to determine the negative predictive value of PET-CT for clinically N0 neck on the basis of neck dissection. The primary endpoints are to calculate the negative predictive value for PET-CT in the evaluation of N0 neck and to look for the impact of PET-CT on surgical treatment plans. It is a prospective non-randomized multi-center study. A total of 287 participants more than 18 years of age were recruited. All participants were newly diagnosed first-time clinical head and neck squamous cell carcinomas. The inclusion criteria include participants having head and neck squamous cell carcinoma in the oral cavity or oropharynx, including the base of tongue and tonsil, or the larynx, including the supraglottis. Exclusion criteria is those patients whose blood sugar is more than 200 milligram per deciliter. In these patients, at least one side of the neck which is planned for surgical dissection was clinically N0 according to physical evaluation and pre-operative MRI or CT scan. The definition of a clinical N0 neck is no palpable lymph nodes, or on CT and MRI imaging a size of less than 1 centimeter or less than 1.5 centimeter in level 2A, 2B and 1 lymphatic levels, and also absence of central lymph node necrosis in any of the nodes of any size. All the 287 participants who had enrolled had undergone a neck dissection. It is defined as removal of at least 3 levels of lymph nodes on the side of the neck that is identified as N0, or occasionally on the other side also, if indicated because of the proximity of the primary lesion to the midline or because of anatomic subsites which has got high propensity for bilateral lymph node spread. These participants, they received a pre-surgical FDG PET-CT scan to which the surgeon was blinded, and also a contrast enhanced MRI or a CT scan of the neck, all within 1 month of surgery. The surgical plans were devised by the surgeons on the basis of the physical examination and CT and MRI results, but not on PET-CT. So this is classified as pre-PET-CT surgical plan. And again, another plan was formulated after getting the PET-CT result. This is termed as post-PET-CT surgical plan, and both the pre-PET-CT and the post-PET-CT surgical plans were collected prospectively. Regarding the statistical analysis, as mentioned, 287 participants were enrolled, and the imaging results and the pathological evaluations were analyzed at the level of the neck, summarizing all the lymph node basins on left and the right sides separately, and also correlating with the pathological findings, defining the final N0 status. The analysis was first performed using a whole body scan when dedicated head and neck scans were not available, and these are defined as best available FDG PET-CT scans. And again, all participants, also head and neck scans defined as head and neck FDG CT scans only, were also done for some patients. So a subset analysis was performed. The proportion of negative pathological results were computed for the necks with negative visual assessment, that is negative prevalence value estimation. This is the participant data. Here we can see out of 287 patients who are enrolled, 248 are found eligible. The most common tumor subsite being oral cavity, roughly around 64%. Clinical stage most commonly in T2, and out of these 248 patients, 208 18 patients, that is around 87%, had a clinically N0 neck. So in this study, out of this 248 patients, 313 lymph node sites with N0 necks surgery was planned. After getting a PET CT done, it was found that only 143 of these neck nodes had a PET positive, 170 had PET negativity, and among these 313 patients, 43 of the patients, the reference standard could not be obtained because of various reasons. So 270 patients reference standard could be obtained, out of which 120 had PET positive necks with reference standard and 144 had PET negative neck with reference standard. So as mentioned in the flowchart above, we can see here there are 313 neck sites which were evaluated. 43 patients, the analysis could not be done because of various reasons. And comparing this 270 patients who had analysis, we could see here on comparing the FDG PET imaging with the final histopathology, we could find that in the best available whole body FDG PET scan, out of 144 patients who were found to be negative N0 on PET, on histopathologically it was found that 125 patients had had negative lymph nodes in pathology also. So the true negativity was 125. However, out of this 144 patients who had N0 as per PET, it was found that 19 of these nodes were found to have positive metastasis on histopathology. Likewise, in head and neck FDG PET CT scan, out of 122 neck nodes which had which were found negative as per PET, after histopathology it was found that 106 of these were true negative and 16 of the lymph nodes were found to be having metastasis. Next is regarding the visual assessment of CT scan, and we can see here for N0 neck sites, out of 270 neck sites, on calculating the negative predictive value, 125 were found to be PET negative out of 144, giving a negative predictive value of around 87%. And taking into account only the head and neck FDG PET scans, out of 234 neck sites, 106 were found to be having true negative, so giving a negative predictive value of roughly 87%. These are the results of negative predictive value depending upon the standard uptake value. The maximum standard uptake value was taken as 1.8. The lower limit of the SUV maximum was taken as 1.8 in this study. As we can see here, if you take the SUV maximum as 1.8 to 3.5, we can see in all the findings, the negative predictive value ranges from around 94% in both the best available scan as well as in the head and neck scans only. This gives a higher negative predictive value as compared to visual assessment. In the previous slide, we mentioned that the negative predictive value depending upon only visual assessment of the CT scan imaging is around 87%. However, if we look at the standard maximum standardized uptake value of all the nodes from 1.8 to 3.5 value, we can find that the negative predictive value is higher. It is around 94%. So the negative predictive value for SUV maximum is higher than that for visual assessment. So in general, the negative predictive value for a pre-specified and optimal cutoff were more than 9.37. A subgroup analysis of negative predictive values were done for each of the tumor stage and location, which were not found to be any significant. There were around 10% of false positive rates, with the highest level in the level 2A, approximately around 26%. This is an example of some images where we can see on the right side, it is a true positive case where the visual assessment is more than 1 centimeter on the left level 2A, and the SUV also shows good uptake more than 3.4. So this case is a case of true positive where both the visual assessment as well as the SUV maximum was present along with the positive lymph node in histopathology finding. Next is a true negative case scenario where we can see a very small lymph node on visual assessment, which is N0 less than 1 centimeter, along with negative pathological finding and an SUV less than 1.8. The third case is an interesting scenario where we can see the lymph node is very small, only 4 mm. It is visually N0. However, the SUV maximum it is visible with uptake, and also on histopathological diagnosis the presence of metastasis was confirmed. It is a case of true positive depending upon SUV maximum. However, looking at the visual assessment, this is a case of false negative. That is, despite the presence of lymph node in histopathology, the visual assessment did not pick up any clinically significant lymph node. The last scenario is a case of false negative. That is, on visual assessment also, the lymph node size was less than 1 centimeter, and on a standardized uptake value maximum of 1.8, there was no uptake of the lymph node. However, on pathology, presence of metastatic squamous cell carcinoma was found. So this is the case of false negative. In this study regarding the impact of change, which is brought by PET-CT imaging, out of the 242 eligible participants, documentation could be about the surgical possible change in surgical plan was obtained in only 237. Out of this, 5 participants without documentation, 1 had undergone surgery elsewhere, 2 decided not to have surgery, and 2 had an unknown surgery status. Out of these 237 patients which surgical plan was obtained, the treatment plan was changed in 51 of these patients after the post-PET surgical treatment was compared with the pre-PET surgical treatment plan. So roughly around 22% of the patient, the surgical treatment plan was changed on the basis of the finding of the PET-CT. And if we look into the nodal level status, 2,424 nodal levels from 303 sites on necks, with both the pre-PET-CT and post-PET-CT documentation of the surgical plan was obtained. Out of this 2,424 nodal levels, we could see that 48 of the nodal levels, that is around 2%, the nodal basins, the plan were added to the previous plan, and out of this 76 nodal basins were removed from the surgical plan, and in another, out of 51 patients, in 34 patients had a planned dissection of additional lymph nodes. 6 patients out of 51 had a planned dissection of fewer lymph nodes, and 4 out of 51 patients had both additional as well as fewer planned dissection of nodes, and in one patient the details are unknown. So we could see that in a very high percentage of patient, there is 51 patient, there is around 22% of the patient led to the change in the plan of surgery after comparing the post PET CT imaging and the pre PET CT imaging. The reasons of 6 of the patients in whom surgery was cancelled were they were influenced by the PET findings. The first patient had a large tumor. The second patient, because of extended lymph node metastasis, radiotherapy was preferred. The third patient had a presence of lung cancer. In the fourth patient, chemoradiotherapy was preferred. The reason not mentioned. In the fifth patient, because of the extent of the tumor, surgery was not possible, and the sixth patient had a locally advanced tumor. And also, depending on the PET CT, there were the presence of distant metastasis as well as other secondary primaries were also found. There were 15 incidents of metastasis in the lung, 1 each in the breast and the bone, 3 in the colon, 3 in the thyroid, and 1 was suggestive of a lymphoma, and 1 of a parotid involvement. There were 10 incidents of contralateral tumors, of which 5 were biopsy proven and 5 were not biopsy proven, and there were 1 incidence of presence of retropharyngeal lymph node. So the advantage of PET was it also picked up presence of distant metastasis and other secondary primaries, and also the presence of retropharyngeal lymph node. When a concordance was done among various readers and combining all the readers, there were 241 sides of necks which were classified out of the 313, and the overall percentage of concordance among the readers for visual assessment was 77%, and the concordance among the readers for maximum value of standardized uptake assessment were 91% at 1.8 SUV, 92% at 2.0 SUV maximum, 93% at 2.5 SUV maximum, and 97% at 3.5 SUV maximum. So in regarding the concordance among readers, it is also found that the negative prevalence of SUV maximum was more than that of the visual assessment. So this is the first prospective multi-center study to show that negative prevalence value of FDG PET is greater than or equal to 87%. The negative prevalence value of PET CT using visual interpretation specific to only clinically N0 site is around 87%. However, they obtained a higher negative predictive value if analysis using SUV maximum was done specific to the nodal basins, which is around 94%. And regarding the concordance among readers, the visual analysis assessment was 77%, that is around 80%. And using the best available PET CT scan results, you could find that out of 144 PET positive, PET negative lymph nodes, 125 did not show any positivity on pathology, which gave a negative prevalence value of around 87%, which is quite high. And 19 of these 144 PET negative lymph node showed positive disease in pathology, so a false negativity of 13%. In addition, regarding the change in treatment plan, after the PET CT results were compared with the pre-PET CT surgical planning, there was a change in the surgical treatment plan in 22% of the study group. So it is better to use a combined approach of visual analysis along with an SUV maximum cutoff point of less than around 1.8 to 2 to accurately assess the neck to exclude any presence of nodal metastasis. This study had several strengths. It reflects a case of mixture of cancers. It represents a practical application of PET-CT to clinically N0 neck and is not constrained by artificial inclusion criteria. The decision to prophylactically dissect the neck before knowing the PET-CT findings and then making any changes once knowing the PET-CT findings were not scripted in the study protocol. However, there is a limitation of this study. That is, because it is a multi-center trial, the lack of central pathology review for all these patients was not there. So, in the conclusion, the study concluded that the PET-CT has a very high negative prevalence for N0 head and neck squamous cell carcinoma. Maximum standardized uptake value analysis is found to be superior to visual assessment with regard to negative prevalence value. There is a high degree of reader agreement for PET-CT of the patient with N0 neck, and all these findings suggest that FDG PET-CT may assist the clinician in deciding on the best therapy for clinically negative neck in head and neck squamous cell carcinoma. However, well-designed clinical trials need to be performed to test the outcome of omitting neck dissection by using PET-CT. Some other articles which refute or related to the parent article. The first of them is published by Carcel et al. In Journal of Oral Maxillofacial Surgery in 2013. The use of multiple time point dynamic positron emission tomography CT in patients with oral head and neck cancer does not predictably identify metastatic cervical lymph nodes. It is a prospective cohort study. The inclusion criteria is a diagnosis of oral head and neck cancer and patient consent to participate in the study. The exclusion criteria is lack of consent to participate. Patients with oral head and neck cancer underwent a consecutive imaging at 9 time points with PET-CT ranging from 60 to 115 minutes. The primary predictor variable was the status of lymph node based on dynamic PET-CT imaging. And the primary outcome variable was the pathological status of the lymph node. An SUV of more than or equal to 2.5 was used to identify a metastatic lymph node. All these patients, they underwent a neck dissection. The clinical decision making for the type of which neck dissection to be done was not influenced by the results of the PET-CT scan. N0 neck, they underwent the supraomoid neck dissection. N positive neck, they underwent the type 1 modified radical neck dissection. There were 74 non-randomized non-consecutive patients who underwent 83 neck dissections. In this 74 patients, 69 patients had neck dissections for the diagnosis of squamous cell carcinoma of the oral cavity. In one patient, the dissection was performed because of squamous cell carcinoma of the skin of the scalp. In 3 patients, the surgery was performed because of metastatic papillary thyroid carcinoma of the cervical lymph nodes. And in 1 patient, the surgery was performed because of a high-grade mucoepidermal carcinoma of the oral cavity. In this study, there were 2,223 lymph nodes which were evaluated in the 74 patients. In 74 patients, 83 neck dissections were performed, out of which 2,237 lymph nodes were evaluated histopathologically, and out of these patients, only 119 lymph nodes were found to be hypermetabolic as per PET-CT scan. This being a retrospective review, we could obtain only the number of N0 nodes which were found to be N0 depending upon PET-CT. So 33 patients out of 74 had N0 node as per the PET-CT finding. So if you compare here the primary predictor variable, that is the PET-CT scan result versus the histological analysis of lymph node, 119 lymph nodes were found to be hypermetabolic depending upon the PET-CT. Out of this 119, we could see here PET positivity was present in 53 of the patients. However, in these 53 patients, only 35 of the patients had lymph node positivity in the histopathologically. So the true positive was only 35 patients. So on calculating here, we can see that the sensitivity was around 60%. It is very low. The specificity is around 70.55%, which is again quite low. The positive predictive value is around 66%. And most importantly, the negative predictive value, that is, you could see here among these 119 patients, only 43 of the patients are true negative. That is, they did not show any presence of metastatic node either in histopathology as well as in PET-CT. So giving a negative predictive value of 65.2%, which is very low. So this study concluded that because of the very low sensitivity and very low negative predictive value, a dynamic PET-CT imaging does not permit the surgeon to depend only on the results of PET-CT study to determine which patients will benefit from a neck dissection. And so, surgeons should better continue to rely on clinical judgment and maintain a low threshold for executing neck dissection in patients with oral head and neck cancer, including those with N0 neck. Another study done by Park Zeti and was published in Radiology is 18 Furoxy FDC PET-CT versus CT MRI imaging and the prognostic value of contralateral neck metastasis in patients with head and neck squamous cell carcinoma. It is a prospective study with the objective to evaluate whether contralateral neck metastasis from previously untreated head and neck squamous cell carcinoma can be accurately detected by combined CT MRI imaging and PET-CT and to assess the prognostic value of contralateral neck metastasis. There were 160 patients with head and neck squamous cell carcinoma which were pre-operatively evaluated using PET-CT and CT or MRI imaging, and the histological results of the neck dissection samples serve as a reference standard for all these 160 patients. In this patient characteristic, we could see here 66 out of 160 patients, that is around 41%, belong to clinically N0 staging. That is quite a large number. And out of this 160 patient, 94 patients had a neck metastasis on 231 sites and 974 levels. As mentioned, in 60 patients, clinically there was N0 in 60 patients, that is around 41%. And in this study, it was found that the FDG PET-CT was significantly more sensitive than either CT or MRI imaging, as in the per patient, per site, and per level analysis. In all this analysis, it was found that the PET-CT was found to be more sensitive than the CT MRI imaging, all were significantly different. And also on evaluating the per site basis, evaluating the contralateral neck, it was found that FDG PET-CT was significantly more sensitive compared to CT MRI. You can see here in the table, comparing the CT or MRI imaging along with PET-CT finding, we can see the PET-CT was found to be more sensitive and more accurate as per patient analysis. On the neck site analysis also, PET-CT was found to be more sensitive with a p-value of less than 0.001% and also more accurate. And also on evaluating both the ipsilateral and the contralateral side, we can see the PET-CT scan was found to be more sensitive in both the ipsilateral as well as in the contralateral side, and also found to be more accurate on evaluating the contralateral side. And also on evaluating the neck level, the PET-CT scan was significantly more sensitive compared to the CT or MRI imaging, and also was found to be more accurate in both ipsilateral as well as contralateral side. So the study showed that PET-CT imaging compared to CT or MRI imaging was found to be more sensitive and accurate as per patient analysis or per neck site analysis or both ipsilateral as well as contralateral site analysis. So this study concluded that PET-CT is useful for detecting cervical nodal metastasis and is more sensitive and accurate than CT MRI imaging when evaluating either the contralateral or ipsilateral side of the neck. So it is an effective negative prognostic factor. Contralateral neck metastasis from head and neck squamous cell carcinoma can be readily detected using FDC PET-CT scan more than CT MRI imaging. And this improved detection of contralateral neck metastasis may help guide the clinicians when selecting or thinking of bilateral neck treatment. Another article is by Sung-Hyu Lee et al. Diagnostic value of only FDC PET positive lymph nodes in head and neck squamous cell carcinoma. The objective of this study was to evaluate the diagnostic value of only the PET-CT positive lymph nodes without correlating the positive findings on conventional imaging modalities, that is either CT scan or MRI or an ultrasound in patients with head and neck squamous cell carcinoma. It is a retrospective case series, was done in Hallym University School of Medicine in Seoul, South Korea. 114 patients with head and neck squamous cell carcinoma from January 2006 to September 2009 who underwent imaging either in the form of CT, MRI, ultrasound and PET-CT before undergoing a definitive surgery with neck dissection were reviewed. All these imaging tests were interpreted and were compared with the histopathological findings. And in this study also, an SUV of more than 2.5 was used to suspect malignancy. And you can see here in the above table, here is a comparison of each of the preoperative imaging modality with the histopathological findings. We can see here on comparing CT, MRI, ultrasound and PET-CT. PET-CT scan has got the highest sensitivity, around 70%. However, the difference was not clinically significant, but the specificity of PET scan was lower than other three modalities. The specificity was less than 90%, while in the other three modalities, the specificity was more than around 94%. Also, the accuracy of PET-CT was less than the other three modalities. The negative predictive value in all the four modalities are almost similar. So the result was that the PET-CT seems to be more sensitive, but it is less specific. However, there was no significant difference. If we compare only the lymph nodes which are found to be positive in PET-CT and correlate with the histopathological findings, we can see that in N0 neck, there were 34 nodes which were N0, out of which 27 are in the ipsilateral side and 7 are in the contralateral side. So if we compare the PET positive along with histopathological finding, it was found that 27 of these N0 lymph nodes are 28 of these N0 lymph nodes are having false positivity. That is, all the 7 lymph nodes from the contralateral side and 21 lymph nodes from the ipsilateral side had a positive metastasis on PET scan, but did not show presence of any metastasis in histopathology. So the false positive was 28. And comparing to the N positive neck nodes, out of 14 patients, 10 are from the ipsilateral side and 4 are from the contralateral side. We could see that 7 patients had a false positive ratio. That is, the false positivity is around 50%. So the result was, in those lymph nodes which are found positive in only PET CT scan, in 33 patients, 48 nodal levels were found positive in PET CT only and negative in ultrasound, MRI and CT scan. Out of this 48 nodal levels, 35 were found to be false positive. That is around 73%, which is a quite high number. And in this 48 nodal levels which were only PET CT positive, 14 nodal levels were included in the N1 and 34 nodes were included in N0 neck. So if we take only those patients who had N0 neck into account, there was a very high false positivity rate. That is, 28 out of 34 patients were found to be having false positive, PET positive and negative on histopathology, with a significant p-value of 0.034. So it was found that 11 only PET CT positive nodal levels in 10 patients were found on the contralateral side, and if we take into account only the contralateral side in which 11 positive nodal levels were found, a false positive rate of 73% was there, which is more significantly more than the percentage of true positive. The true positive was only 30%. So out of 11 nodes, 8 were found to be false positive and 3 were found to be true positive. So taking into account the N0 neck and the contralateral side, the false positive rate in PET was very high. And also regarding the demography of the patient, we can see here, like our parent study, those lymph node level 2 had a very high incidence of false positivity in PET despite having an N0 neck status. The mean standardized uptake value of only the PET CT positive lymph node was 4.2 with a range of 2.6 to 5.3 in those patients who had a true positive neck metastasis, and the SUV was 3.2 for those with a false positive report. The mean size of only the PET CT positive lymph node was 1.10 centimeter for true positive and 1.05 for false positive. So there was no significant difference in the mean SUV or the lymph node size between the true positive and false positive. So it concluded that in only the PET CT positive lymph nodes, it can be frequently found in cases of oral head and neck squamous cell carcinomas, and they do not predict lymph node metastasis. A very large number of false positive findings are present in only the PET-CT positive lymph nodes, and the false positive findings in N0 neck and the contralateral neck are found to be statistically significant. So, the management of the neck should not be based on PET-CT finding alone, and presence of only PET-CT positive neck should not affect neck treatment selection. And this suggests that if a patient was found to be only PET-CT positive lymph node and negative on CT MRI or ultrasound, especially in an N0 neck node or on the contralateral side, the neck node should be considered as negative. Another article published by Joshua K. et al. Is a preoperative 18-FDG PET-CT versus contrast-enhanced computed tomography to identify regional nodal metastasis among patients with head and neck squamous cell carcinoma. The objective was to compare the accuracy of preoperative PET-CT and contrast-enhanced CT in detecting cervical nodal metastasis in patients treated with neck dissection and to scrutinize the ability of each modality to determine the nodal stage. It is a retrospective study done in New York. Patients who underwent a neck dissection for primary treatment of head and neck squamous cell carcinoma and had received preoperative PET-CT and contrast-enhanced CT scan were included in the study. The imaging studies were interpreted by 3 specialists. A concordance between radiology and histopathology was measured using the neck levels and sides along with the patient nodal stage. The sensitivity, specificity, accuracy, negative predictive value were calculated. Regarding the patient characteristics, this is the retrospective data, so we could obtain only the status of the pathological nodal status. In this 27 patient, there is around 37% had a N0 pathological status. And in this study, there were 73 patients who were reviewed, and they had 579 neck level specimens. And of this 579 neck levels, 83 resected neck levels and 53 showed histological evidence of metastatic involvement. And in the histopathological analysis, 27 of the patients were staged as N0. And of these 27 patients, 14, around 52% had received ipsilateral neck dissection. 13 patients had received a bilateral neck dissection. So, of the 27 pathologically N0 patients who had no evidence of cervical metastasis on histopathology, 16 patients, that is around 59%, were assigned preoperatively as either N1 or higher stage by the PET scan, and out of these 27, 8 patients, that is 30% of the patients, were assigned a higher stage by CECT. We can see here in the pre-op PET-CT and CT scan comparison with the final pathologically N0 status. In the out of 27 patients who were found to be N0 on histopathology, PET-CT had, out of 27, 16 of the patients had a clinically positive neck as per PET-CT scan, and 11 were classified as N0 as per PET-CT scan. So the false positive was, there were 16 patients who were false positive as per PET scan but found to be negative on histopathology. Likewise, out of 27 patients who were found to be pathologically N0, 8 of the patients were upstaged as N1 or more, depending upon the pre-operative CECT evaluation. So the sensitivity for PET CT and CCT were similar as per the level. However, the PET CT was found to be more sensitive if taking into consideration only the nodal site with a p-value of 0.001. Regarding the specificity, the contrast enhanced CT scan was found to be more specific than PET CT in both the neck level and sides, with a significant p-value of 0.014 and 0.24 compared to PET CT scan. However, there was no significant difference in the overall accuracy. And regarding the end stage, the overall agreement was that the PET CT scan could identify 52% of neck node, and CT scan could identify 55% of the neck node. So they concluded that PET CT was more sensitive than CECT in excluding metastatic involvement of the given neck site. However, there was no difference in the overall sensitivity between the two modalities. And a contrast enhanced CT scan was found to be having a superior specificity compared to PET CT. And both these imaging modalities appears to be complementary, and a continued refinement of application and reporting of these modalities may improve the ability to accurately assess the cervical lymph nodes in patients with head and neck squamous cell carcinoma. So regarding the take-home message, preoperative evaluation in the form of PET CT in N0, in some studies it shows high negative prevalence. However, in other studies it has got a very high false positive rate when it is compared to the final histopathological report. However, it may aid the clinicians in making a surgical planning decision, and the treatment plans may need to be changed on the basis of PET CT results compared with a pre-PET CT surgical treatment plan. Thank you. End करूं? बहुत सारा गिर गया ना यहाँ पे.